This is a short and concise Zoom presentation about epilepsy as it is managed under the NHS in the UK in 2021. As you can see, it has taken on board the NICE guidance, which was initially introduced in 2012 and which has been ratified in 2018. So how does one describe epilepsy? It is a provoked or unprovoked excessive electrical activity occurring in any part of the brain, causing a neurological condition, and which is the commonest neurological condition in the world. Basically, there are three kinds of epilepsy: the generalized onset epilepsy, the focal onset epilepsy, and seizures of unknown onset. The generalized onset epilepsy can be absence seizure, in which case there will be no seizures and there would be absence of mind for a period of time, sometimes preceded by an aura. And in that, the patient behaves in the same way as the patient would with any other neurological overactivity. It can be the typical tonic-clonic type of seizure, or it could just be tonic, or it could be clonic in nature. So this kind of seizure is generally known as grand mal, and it's the one that mainly this presentation is based. And when an unqualified mention of epilepsy is made, that is what is understood by epilepsy. There could be myoclonic seizures, which means muscles are in a state of spasm and that they are continuously in a state of spasm. It could be a flaccid type of generalized seizure when the muscles are either hypotonic or atonic, and the patient can be rolled about easily, but usually is unconscious. Most of the generalized versions of epilepsy are associated with a preliminary aura of indeterminate time in which certain sensory excited symptoms are felt. Generally, one fit is followed by exactly similar next fit. And so these are the usual characteristics. And one needs to remember that almost greater than half of the generalized epileptic attacks do not occur a second time at all. And sometimes this incidence goes on to 90%. However, there are limitations in terms of how one conducts oneself with a history of epilepsy. There are types of epilepsy of a focal nature, and these can produce facial twitch with preserved consciousness when it is called a simple seizure of a focal onset, or there could be loss of consciousness or reduced conscious level, in which case it could be called a complex focal onset. It usually is not characterized by a preliminary aura. Then there are seizures of unknown onset, and these could be serial seizures, almost like stroke in evolution. So there could be one seizure followed by a gap in which the patient may regain consciousness or not, and then have a second seizure of an identical nature, which may be longer than the first seizure. There could be a single seizure which is prolonged in nature. And if it goes on for more than 5 minutes, then of course it assumes the characteristics of status epilepticus. But some serial seizures do not produce status epilepticus. In the UK, about 5 to 10 out of every 1,000 patients and 5% of the over 21 patients suffer from some form of epileptiform condition. Almost 60% patients having had their first attack do not have a second attack. And if an EEG is negative for excitation or a trigger, then up to 90% do not have a second seizure. So what could be the causes of epilepsy? It is established that almost 2/3 of the patients who suffer from epilepsy have a cause which can be identified. It could be an idiopathic condition with no cause found and no explanation at all as to the trigger. It could be a genetic condition, so therefore there is a past family history of first-line blood-related family members who have had epilepsy and no cause in them has been found as well. It could be the result of cerebrovascular accident, and that would mean enhanced TIA, stroke in evolution, stroke, bleeding in the head, or cardiac disorders. And the main features of these are profound arrhythmia, aortic stenosis, and hypertrophic obstructive cardiomyopathy. A lesion which has been characterized by ruptured aneurysm in the brain can lead to a scar which in itself produces mechanical irritation, and the infarcted area or suffering area could also act as a nidus of irritation. This could produce an epilepsy. Space-occupying lesions, mainly cerebral tumors in any part of the brain, can provoke a seizure because of increased intracranial pressure, hydrocephalus, displacement of the midline, producing compression effect in a tight confined space. Head injury is associated also with epilepsy. In this, we are already fully aware of the lucid interval which one sees in extradural hematoma. But extradural hematomas, subdural hematomas, or direct brain injury can result in temporary or long-lasting epilepsy. There are some drugs which includes alcohol, drugs of pleasure, hallucinogenic medication, side effects of certain medications can all produce an epileptic condition. Some infections are characterized by epileptiform phenomenon, such as infections in the nature of meningitis, encephalitis, sepsis, and so on. So how does one assess epilepsy? The process would normally start with taking an on-board history of trauma, of the nature of the fit. Also, if there was a provoking factor, such as an injury or a shock or a recent illness or a previous episode of epilepsy. One would need to make a general examination to rule out thyrotoxicosis, anemia, nutritional status, and obvious features of drug misuse. In the primary care of the UK, one can undertake a 10-minute neurological examination, which is less exhaustive, but relates to conscious level memory establishment, orientation, features of meningism, a few cranial nerves such as second, third, fourth, and sixth nerves collectively, 5 and 7, and also one can examine the movements of the head and the action of swallowing and speech, reflexes, motor power, and sensory examination, an assessment of gait as the patient walks in, extrapyramidal signs, and signs such as swaying in coordination and plantar response. One should make a good understanding of the family history of other family members, particularly siblings, suffering from epilepsy, and what trigger would normally provoke these. When an epileptic attack is described by a witness, then the nature of actual attack, the duration of attack, and as to whether the patient had lost consciousness, had been incontinent, are all assessed. History of trauma is dealt with additional unrecognized injuries as well. In the cold condition, one undertakes blood investigations to rule out implications such as anemia, thyrotoxicosis, or cardiac disorders such as from clinical assessment and ECG. The assessment of EEG and MRI scan is in the hands of the neurologist in the secondary care. But before the neurologist gets to see the patient, some form of treatment needs to be started to prevent the second attack. However, it is in the interest of the system to have arranged a neurological assessment as soon as possible, which would allow some safety measures to take place, such as prevention of driving, also risks to life during the attack, at work, and at home. So how does one differentiate epilepsy of a neurological nature from other conditions? We've already discussed that certain CVAs, including arrhythmia, aortic stenosis, and HOCM, can be confused with epilepsy because they do cause loss of consciousness, and there could be some additional neurological features in the process of observation. Syncope, usually a hypotensive crisis induced by infection, psychogenic conditions, and also from orthostatic conditions, can produce loss of consciousness and sometimes neurological phenomena as well. There could be hereditary conditions and ongoing conditions such as mismanaged insulin, non-compliance with antihypertensives, Parkinsonian medications, and so it should be differentiated from these conditions as well. If there is availability of history of drugs, such as hallucinogenic drugs and drugs of leisure, and also of excessive intake of alcohol or stimulants of a methadone nature, so these can produce features which mimic neurological epilepsy. Generalized trauma by reason of brain devascularization momentarily can produce epilepsy-like condition. Certain infections, such as meningitis, encephalitis, can produce their own effects and the person may have some features of epilepsy. Finally, psychogenic conditions such as panic attacks and other manifestations of acute anxiety can produce similar conditions in some ways. So, how do we treat such patients? Obviously, the treatment starts early, but usually the organized treatment is introduced with the second attack. And there are some preferred medications in the NHS, which are first-line treatment of epilepsy, such as sodium valproate, also called Epilim. And the usual dose of an adult could be between 600 and 2000 milligram per day, but it is generally up titrated from a smaller dose. And so if someone is over the weight of 20 kilogram, then 20 to 30 milligram per kilogram, such as 400 milligrams in all, is introduced as once a day, and it's increased over weeks to the maximum tolerable or when the patient is comfortable. Side effects of sodium valproate are usually known to be some form of dyspepsia of a reflux esophagitis nature. The patient reports tiredness all the time, and there is some degree of weight gain and alopecia. Sodium valproate is contraindicated in pregnancy, and the valproate manufacturers have introduced a valproate pregnancy prevention program. So obviously, this is meant for a woman of a fertile age in whom sodium valproate is used concurrently with an active pregnancy prevention strategy such as copper coil and so on. It's also contraindicated in someone with a history of porphyria. Carbamazepine is also the first-line medication, but sodium valproate is usually preferred, and its average dose for an adult would be between 800 to 1200 milligram per day, and it is present as tablets or suspensions or suppository, and the optimum adult dose is between 800 and 1200 milligrams per day. Side effects include drowsiness, dizziness, blurred vision, and sometimes it interferes with lactose intolerant people in producing digestive disorders. Its contraindication is ischemic heart disease. Lamotrigine or Lamictal is also used as an anti-epileptic medication in the dose which ranges between 100 to 700 milligram per day as single or divided. It's usually begun at a low dose of 25 milligram, and then 2 weeks later, it is increased by fractions of 50 milligrams. And then, of course, the maintenance dose could be between 100 to 200 milligrams per day. However, it works in 6 weeks' time and is not of an immediate effect. The side effects include rash, headaches, and the contraindication is liver, kidney disorders, and pregnancy. Levetiracetam, also called Keppra, can be used between 250 to 3,000 milligrams per day, but it is introduced gradually as 250 milligrams BD, and then every 2 weeks the dose is increased, and the usual maximum is 1.5 grams given twice a day. Side effects include vasomotor disorders, unilateral headache, low mood, deliberate self-harm, and depression flare-up. It's contraindicated in pregnancy. Topiramate also called Topamax, and it's usually given as 100 to 200 milligrams per day, but it starts off with 25 milligram Nocte, and a week later, gradual increase is made. When it is in use, there is a need to take calcium, and the side effects include glaucoma and kidney stones. What are the implications of epilepsy in the UK? The first implication relates to drivers and vehicles licensing organization. And the DVLA at a glance document is present in the internet and gives advice both to patients as well as to the clinicians. So a person who has a Group 1 license, which is a license for driving an ordinary car, but the same person can drive a motorbike as well, but cannot drive trucks and lorries on a regular basis. So such a person would have an automatic ban, self-imposed and advised by the GP, on someone who has had the first attack of epilepsy. And this is an epilepsy which is unprovoked. The same person, if he has had an epilepsy which has been provoked by things like photophonophobia or severe injuries, should stop driving for at least 1 year. First attack in class 2 holding licenses, such as drivers driving lorries and trucks, will have to show that they have been epilepsy free without medication for 5 years before their suspended license is renewed. If a person has provoked epilepsy and holds a class 2 license, such as being able to drive heavy goods vehicle, such as a lorry, then such a person would need to remain fit-free for a period of 10 years, during which he is not on any medication, for that person to have a restoration of his driving license. Public service driving license holders, such as train drivers or bus drivers, will need to be individually assessed. But in general, they are held permanently unsuitable for driving the vehicle which has charge of public. There are implications of safety at work. So the HR department of the organization needs to be informed by the patient themselves, and they should have provisions of his safety, such as fall from the stairs or injury from sharp objects, and whatever the occupational health advisor can think of can be put in place, measures put in place to prevent any injury during an attack. We have already discussed about pregnancy, and so the neurologist needs to be consulted along with the gynecologist as to what to do if implications of impending pregnancy or current pregnancy are at hand. One should screen for depression by the usual 3 questions. Do you feel low in mood? Do you feel that the future doesn't hold anything good for you? Are you low in your mood all of the time? And of course, there are degrees of assessment with this, such as suicidal ideation, and thoughts of deliberate self-harm. Long-term management is between the epilepsy nurse, the primary care, the employer of the patient, and the patient themselves along with their family. Prevention is key in this matter. Fits in children have assumed a special position, and I'm not including in this presentation how to control fits. I hope you have enjoyed this presentation, and I will be hoping to make further presentations in due course. Thank you very much for listening.